want to welcome all of you to our podcast focused on lung cancer. And I'm Dr. Loretta Loftus. I'm president of the Southern Medical Association this year, but I'm also a professor and senior member at Moffitt Cancer Center in Tampa, Florida, and University of South Florida College of Medicine. And I'd like to introduce Dr. Lary Robinson, who's a professor and senior member at Moffitt Cancer Center and uh, very involved and a faculty member in the thoracic oncology program at Moffitt. So thank you, Dr. Robinson, for joining us today. Um, I was wondering to start, if you would be able to share a bit about your background and what motivated you to pursue a career in thoracic surgery.
Well, my interest in thoracic surgery actually started when I was a kid growing up in Kansas. My father was a general practitioner, and he also had some special training in anesthesia. And he would go to the local hospital and do the anesthesia for the general surgeons in town. And I used to go when I was, young and middle school and in high school and watch some of the surgery. And after I was there for a while, this is many years ago, I was asked to scrub in and hold some retractors, which I did on some of the cases. And I got very excited about surgery in general. That sort of started my interest. And then I ended up going to medical school, Washington University in St. Louis. When you're in medical school, you rotate through all the various specialties on the third year. And I'd go through OBGYN and all the rest of the specialties. And it was surgery really got me excited. And then I went through thoracic surgery. I rotated through and was very excited at that time. That was a real start of open heart surgery. And I just was sure that's what I wanted to do, and ended up at Duke in North Carolina and spent a number of years at Duke and finished my training there. I did have a sojourn as a flight surgeon in Southeast Asia during the Vietnam War, which was even more interesting, but ended up finishing up and at Duke and became a thoracic surgeon. I initially went to University of Nebraska, Omaha, where I did heart surgery and lung surgery. And then 30 years ago, I came down here to Moffitt, where I've been doing mainly general thoracic surgery since that time, and became very interested, obviously, in lung cancer and lung cancer surgery.
That's fascinating, and what an incredible background and training, and a long training too. Um, are there, I know you've probably seen tremendous changes over the years. Are there any particular times and that are especially memorable to you that were life-changing? Um,
Well, I think the things that I've seen so many changes in thoracic surgery where it's become safer and safer so open heart surgery, which I did for about 15 years. We saw tremendous advances in making it safer so people could get through surgery. The development of cardioplegia, so you could operate on the heart, stopped heart, and you could do a lot of very interesting and very complex operations, and patients would do well. Now they're becoming even more minimally invasive for cardiac surgery. Thoracic surgery has changed dramatically. It's become now much, much safer. We operate on people we never even considered, 10, 15, 20 years ago. And the minimally invasive thoracic surgery has really accentuated that. We've also become a lot better at estimating whether or not a patient has removable disease, because the only thing where surgery really helps is if you can remove all the cancer. And in years past, many times we'd go in various operations and find that unsuspectingly the cancer had spread, but with the onset of CT scans, PET scans, and a lot of other technology, we're operating on perhaps maybe less people because it's more appropriate to the people we operate on. I can tell you one thing that really most memorable thing in my career was after in 1983, 2 weeks after I started my first job as a attending thoracic surgeon. I remember there was a nurse who was brought in the emergency room, and she was stabbed in the heart. She was just going home from an evening shift, and a fellow who was let out of prison came by and just went into a restaurant and stabbed her. Actually, it was in the Denny's. They brought her in the
oh,
emergency room, and she was dying there, pumping on her chest. And it was really something right out of a movie. Opened her chest. There was a big hole in her heart. And believe it or not, we took a Foley catheter, uh, put it in the hole in the heart, blew up the balloon, kept it in place so her heart could at least beat, not lose all the blood. Took her to the operating room, put her on pump, closed up the hole, and remarkably, she recovered and went home a week later. Yeah, I
Oh
could say
my
it's
goodness.
probably the most dramatic thing that I've ever done, and it was very gratifying, and it really cemented my feelings about being happy that I'm a thoracic surgeon.
Yeah, that's very gratifying and so dramatic too. Um, again, too, there especially recently some major changes in the systemic treatments too, not just in the surgical management, but systemic management of patients with lung cancer. What do you think are some of those important um, findings? And do you think immunotherapy has had any major impact on the outcomes of patients with lung cancer?
Oh, there's no doubt about that. That's been the most exciting thing that's happened in all of oncology, particularly lung cancer when it first came out. It's been a real godsend for people who have advanced disease. Now that we see patients who come in and respond to immunotherapy, and they'll be followed. Now we're up to years. In fact, our thoracic oncologists are kind of afraid to use the other C word, cured,
Hmm.
but because they have people who are out 3 and 4 years with metastatic cancer of the lung. And we're also now, as people try many innovative approaches, we're able to give people who have locally advanced disease, metastasis in the mediastinum and so on, who may be resectable, give them immunotherapy and chemotherapy up front, and then make them resectable and operate on them and take it out. And cure rates really dramatically increased. Also, patients who've had surgery have a higher risk for recurrence. Giving them immunotherapy and various therapies after surgery has increased our cure rate dramatically. So it's been a not only for medical oncology, but it's in a combination of surgery and medical oncology to make a difference. But it's really, in fact, I often tell the patients they had to change the computer for appointments for the medical oncologist. It used to be the medical oncologist would have NP or new patient appointments, and then they'd have a few established follow-up patients appointments, but they didn't need to have many because, frankly, the patients would die and they wouldn't be followed up now. And they actually had to
Hmm.
change the computer so there was many more established patient visits for each medical oncologist because patients weren't dying. They were coming back again and again and again. I can't tell you how many people I've done pericardial windows on with stage 4 disease who I've seen in the halls come up to me and say, you probably forgot me, but you operated on me 3 years ago and took out drained my pericardium, and I'm still doing fine. So it's very exciting to see the advances both in early stage and late stage disease.
I I think especially what's so important too in a change is the increasing importance of the multidisciplinary approach to the care of these patients. Um, not just lung cancer, but across the board with we certainly have seen that in breast cancer and other cancers. But the collaboration of the surgeons with medical oncology and radiation as well, and also the development of new drugs all along the years. So yeah, it's been very impressive to see how patients are living longer and having good quality of life too. Um,
Multidisciplinary care has been, in fact, when I first came here 30 years ago, I was so impressed how Moffitt was geared toward involving the surgeons. And they weren't over at many places, surgeons in a silo over there in the Department of Surgery, and then the medical oncologists on the other place. And they didn't really seem to interact. And the thing they've done here at Moffitt is they've put everyone together. For example, we have it's multidisciplinary, not only conferences, but our entire department is thoracic oncology. My boss is a medical oncologist, not a surgeon. So the medical oncologists, the thoracic surgeons, the radiation oncologists, the pulmonologists, all in the same department. We're all in the same area of the same clinic. We're in the same place where our offices are, and we interact together. So it really brings things together. I'll be in the clinic seeing a patient, new patient, and I'll have a question about whether they should get on, what kind of treatment they should get. and I go right next door to me in the next computer is senior thoracic oncologist who's seeing other patients. And I can easily grab that person, have them take a look at the x-rays, discuss them, and I have a immediate consultation with a thoracic oncologist. So the person who comes to see me actually has the benefit of having a number of different specialists potentially seeing their case.
I know I find it so incredibly valuable in taking care of patients, and we have a similar way of seeing patients and multidisciplinary approach for breast cancer as well, which was very attractive to me to be at Moffitt. Um, so, how what kind of information or how do you go about getting the word out to patients and primary care physicians who are seeing a lot of patients about the importance of lung cancer screening, prevention, and um, treatment? Uh, um, I'm sorry, early detection and treatment.
Well, lung cancer is eminently curable if you can find it early. The problem is when
Hmm.
it's early, almost never, very rarely do they have any symptoms. So if you wait till they have symptoms, it's usually later stage disease and the cure rate drops dramatically. Well, fortunately, we've known now for at least about 15 years that you can do low dose screening CT scans on people who are at high risk, and you'll find a quite significant number of lung cancers and the vast majority of those early stage curable cancers. If you take the current recommendations are for someone who has at least 20-pack-year history of smoking, someone who's over the age of 50 and has quit smoking within, say, the last 15 years or so. Now that's puts us there's about 14.5 million people in the United States who are eligible for that. And we're trying to get people in to get screening CT scans. Unfortunately, so far, we haven't been that successful. We're only about 15, 16% of the people eligible to get screening CT scans have them done. So we're trying to get out the word by going out to see the people in the community, both the patients themselves, the community physicians, because screening CT scans for this disease, it's relatively new. We've been doing breast cancer screening with mammography for many decades, and same way with looking for cervical cancer and prostate cancer and so on. And the screening rates are very much higher. It's probably 75, 80% of women who are eligible to get mammography get that done. We're about 15, 16%. That's come up some. But there's an enormous amount of patients we could really help. For example, if you just take Florida, we estimate there's probably 1 million people in Florida who are eligible to get screening CT scans. And if we could get every single one of those folks theoretically to go get a screening CT scan, we'd find about 15,000 cancers, of which 12, 13,000 are early stage, and we could probably cure at least 10,000 of them. As it is now, we have about 20,000 cases of lung cancer are found every year, and we cure about 4,000 of them. So we can make an enormous dent by doing screening CT scans. And there's a lot of reasons why people don't get screening CT scans. A lot of it is just they're afraid to get CT scans. They're afraid they might find something. A lot of times they don't know about that. The physicians themselves don't ask about it. And one of the things is because there's a certain number of people who are eligible, unlike say, who gets breast mammography. If you have breasts, you should have mammography if you're over the age of, I think, 45. Lung cancer screening is a certain number of people. Now, having said that, there are people who are not ineligible for screening CT scans who will get lung cancer. And of course, the epidemic of never smoking females and males getting lung cancer has been a dramatic change over the last 10, 15 years. 25% of the women who get lung cancer are never smokers, 10% of males. So we're looking at that. There's other risk factors for it, but it's that's something else to get. But essentially the low hanging fruit is to get people who are at high risk we know of to get in and get their screening CT scans. And it takes 15 minutes at the most. It's simple. It doesn't hurt. Unlike I'm sure mammography is not very much fun. So it's something that we'd like to get people out to.
I've been very impressed with the work you've been involved with at Moffitt. on outreach to the community, really very innovative work on reaching community physicians and patients to get the word out, but also providing increased access with the CT scan that's in a bus to go around to the community. I'd like to hear more about that too.
Well, we're very excited about starting this past November. We were able to get a screening CT scan, actually a top of the line CT scanner, Siemens, and they have a entire unit, self-contained unit. It's sort of a large truck. It's not a semi-trailer truck, completely self-contained, has its own generator, air conditioning system, and you don't have to find some place where you can plug in. You could stop in at a parking lot. You stop the truck, a couple legs go out from it, it gets itself leveled up. You turn on the lights, open the door, and you can screen people. And this has
Wow.
worked out marvelously well. And it's all self-contained, and you pick up and you leave. And actually, when the CT scan, which takes it's a single breath hold, the CT scan is then transmitted electronically back to Moffitt to our radiologist to read it, and we call the patient within 3 days to let them know the results. So it's very effective, and it took off in November, and we can do about easily 15 new patients in a couple hours, stopped at one place. So they've been out at various places, and it really improves access. Tampa's become a very large city, and there's a lot of places around the outside that older people, kind of reluctant to come in the city to get a screening CT scan. And so we're able to go out in the counties and arrange to have then people just register ahead of time. They come in and they just sign in and they go get the CT scan. They're in and out in 15 minutes. So it's very effective, and it's made a lot more access available in places where there's not array access.
Yes, it seems to me an incredible model for across the United States for doing something like this, and even for other types of cancers. Um, so, surgery can certainly be taxing both emotionally and physically for a surgeon. Um, how do you deal with the stress and keep up your motivation to avoid burnout?
Well, the motivation is relatively easy because I'll see patients who come in. I mean, it's very exciting to see someone who has a cancer that could kill them, but is still localized. Take them to the operating room. 2 hours, 2.5 hours later, the cancer is gone. Those people are going to live and not have to worry about the lung cancer. Now they may get something else they need to be followed along. And then you see them back in clinic and they recover very rapidly. But surgery becomes so very safe now. We can operate on lots of older individuals. For example, there was a lady, and I remember her very well, lived on the other coast, and she came over. She was 82 years old. She had a big cancer in her left upper lobe. We took out her left upper lobe. She did fine, as if nothing happened. She was amazing, former smoker. She came back 6 years later with a new cancer in the right upper lobe.
Hmm.
And by this time, she'd reached 90 years old, but she was still very active. And we talked about it, and we talked about it. Took out her lobe on the other side.
Wow.
She did fine, and she lived another 10 years, died at the age of 100, and she was known over in this retirement community she was at as being the real guru on the shuffleboard court. So and I know about her because she'd send me some cookies every year at Christmas. So I mean, these are the kind of things that make, I'd get night calls, and I'd worry about patients all the time. But you get sort of used to that stress. Chronic stress is probably not as severe as acute stress on as far as the individual is concerned. But I have the support of a marvelous wife, and and all the people here at Moffitt. It's been really gratifying. So I've been able to cope with that. I have a lot of other things I do. I run, I ride bicycle, I write a lot of things, and I play piano. I mean, there's a lot of things you have to be able to do to take your mind off of worrying about patients. But it's a 24-hour job, and but I've gotten used to it. And I've done it for 40 years.
Yeah. Yeah. Um, well, Dr. Robinson, thank you so much for all of your great information and knowledge and wisdom. We greatly appreciate your participation in this program. And to our listeners, I want to invite you to send us any questions you have, and also suggestions for future presentations. And stay tuned for a lot of upcoming interesting topics. Thank you so very much.
Well, thank you for inviting me. Appreciate it.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.